So now we are going to discuss the topic of hearing devices. Now this may be the last topic of the ears unit, but this is a very important topic. A lot of questions are asked from this hearing devices and the latest advancement in these hearing devices. Now I understand that before coming to this topic, you have gone through the whole ear unit. You have understood the hearing loss, you have understood the types of hearing loss, the diseases which are causing the hearing loss. And I have discussed these hearing devices then and there between the diseases also. Okay, but this video, this topic I am making so as to revise all the hearing devices for you in one place and to discuss some of them which I have not been able to discuss in the diseases. Okay, so this will be a culmination of all the hearing devices together, right? So let's start with number one. We discuss the neural pathway. Okay, so we remember the neural pathway. The neural pathway is E. coli Ma, right? Remember, E was the nerve, coli was the brainstem, and Ma was the cerebral cortex. Okay, so E was the eighth nerve. Then we had the cochlear nucleus. Okay, then we had the contralateral superior olivary complex. Then lateral lemniscus, I was for inferior colliculus. So that was the brainstem. And then we had the Ma, medial geniculate body, and the auditory cortex, Brodmann's area 41. So these were the cerebral cortex. So why I am revising this for you? Because at each of these pathway, okay, especially the first three pathways, we have the cochlea, right? Number two, we have the eighth nerve, and number three, we have the cochlear nucleus. These are the three important places where we are going to discuss about the hearing devices. All right, so let's start with the number one hearing devices, and those are the hearing aids, right? So these are the simplest hearing devices. I'm using the word simplest. Technologically, they have advanced quite a lot, so they are not simplest, but for our understanding, they are the outermost devices which are body worn, and we see them most commonly. Okay, so I'm going to talk about the hearing aids. There's a number one device that we are going to study, and there are two types of hearing aids. Which two types? Number one, analog, and number two, digital. Okay, so now when I say analog hearing aid or digital hearing aid, that just means the technology. What do I mean by analog hearing aids? Now analog hearing aids, they're just like an amplifier, a simple amplifier. So what do? They take the sound, amplify the sound, and give it to the patient. Okay, it's a simple amplifier, so it will take all the frequencies of sound, just like you use a loudspeaker in the music program, in the party. So that takes the sound, amplifies all the sounds, and gives them. Okay, so that's the function of an analog hearing aid. Now analog hearing aid may not be that useful. Why? Because generally the patients, they don't have same loss in all the frequencies. Okay, so same loss means the patient's air conduction curve and bone conduction curve, they both should be flat. Okay, suppose you want to amplify the air conduction. So let's say this is the air conduction, it has to be flat so that you equally amplify in all the frequencies. So when we studied the hearing loss, we discussed, we saw so many Peotron audiometry graphs, and nowhere we find that these curves are straight flat line. No, they are not. They are ups and downs. So some frequencies have more loss, some frequencies have less loss. So now what happens when you use an analog hearing aid? What is going to happen is that this patient will get some frequencies amplified to the right amount, some frequencies which will be amplified less than the right amount, and some frequencies will be amplified more than the right amount. Okay, so those which are amplified less than the right amount of amplification needed, now what will happen? He will miss those words. Okay, and those where the sound is amplified more than needed, now that those frequencies, he will start having noise induced hearing loss. Okay, because now they are more than the ear needs. Alright, so these analog hearing aids, they are technically not used nowadays. We don't prefer, we don't advise these analog hearing aids anymore. I hope now you have understood that they are just like an amplifier. So now we have a better technology, we go to digital hearing aids. So what does a digital hearing aid means? Digital hearing aid, it breaks down the sound into different frequencies. Okay, so it breaks down into different frequencies, right? So each frequency sound will now be amplified. So based upon that, we have different channels of digital hearing aid. Okay, so whenever you go to talk about the hearing aid to a shopkeeper who's keeping the hearing aids, so to an audiologist I should say, so he will always talk about the channels. Channel means the hearing aid, this digital hearing aid is dividing the sound into so many different parts. Okay, so let's say it is dividing the sound into 100 to 200 hertz. Okay, then 200 hertz to 400 hertz, and then from 400 hertz to let's say 1000 hertz. So 1000 hertz to 2000 hertz, like that. Okay, so it's dividing into different channels. All right, and each channel, each part is then amplified as per the patient need. Okay, so we can have simplest like 2-channel hearing aid. That's the simplest digital hearing aid. Analog hearing aid was a single channel hearing aid. It is amplifying all the frequencies. Okay, so single channel hearing aid, that means analog hearing aid. Right, now we come to digital. So digital simplest can be 2-channel, and we can have up to 128-channel hearing aids also. So they divide the sound into different frequencies or different group of frequencies and then amplify each one as per the need of the patient. Okay, so that's number one. Any other thing that we can use? Now, instead of using one microphone, you see, the hearing aid has a microphone to take the sound, right? So instead of one microphone, we can now have 2 or 3 microphones. What is the advantage of using more than one microphone? The advantage of using more than one microphone is that one microphone is for the speaker speaking from in front of you. Another microphone can be used for the surround sound, right? For the noise, for the music that is coming from the background. We can also have a third microphone which is for the sound which is coming from behind. So we can have multiple microphones, and that can be used in different ways to add the sound, to subtract the sound, just like in the case of a binaural hearing. Right? So we can have multiple microphones also. So now, other than that, nowadays we also have the Bluetooth technology. So why not have this Bluetooth technology in the hearing aids also? You can connect the hearing aid with a cell phone. You can connect the hearing aid with the television. Okay, you can have a small Bluetooth mic also with this hearing aid. Okay, so there is a mic, a separate mic with this hearing aid. Now, what is the advantage of this mic? This mic you can give to the teacher. Suppose there is a child who goes to school, but he has a deafness. Okay, now he is using the hearing aid. This hearing aid has a Bluetooth mode in it. So now you attach a Bluetooth mic to this hearing aid. The mic is given to the teacher who's teaching. So she is roaming in the class and she puts the Bluetooth mic on her collar. Okay, now whatever she speaks, so without any background noise, that all sound is heard by the child. All right, he can be sitting anywhere in the class. Similarly, this can be attached to a conference mic. Right, in a conference, in an auditorium, you're sitting in one place in an auditorium, you're not able to enjoy the music, but if you have a Bluetooth mic, you can request and it can be attached on the podium and you can listen to the whole conference, to the speeches and everything. So there are a lot of things that can be done with the help of a digital hearing aid. Right, so a lot of advancements. Now let's talk about the types of hearing aids. One was analog, one was digital. This another way to classify them, and that is based upon how they are applied. So now that was one way to classify the hearing aids, the analog and the digital hearing aids. There is another way upon how we use these hearing aids, in what shapes they come. So remember, when I talk about the shapes, the number one is the behind the ear hearing aid. Now, behind the ear hearing aid is just a shape in which the hearing aid is applied to the patient. All right, remember, it can be analog hearing aid, it can be digital hearing aid. A same looking hearing aid, okay, can be a single channel or a double channel hearing aid. Single channel means analog, double channel means start of digital. It can be 128 channel. It can have all the different technologies. So just by looking at the shape of the hearing aid, you cannot tell what is the technology inside the hearing aid. right? So just like a car, more or less all the cars, they look alike. There is some basic difference in the shapes of the car on the outside, but what matters the maximum is the engine and the technology which is used inside the car. All right, similarly most of these hearing aids, they look alike. Okay, a behind the ear hearing aid, most of them will look alike, but what is the technology inside these hearing aids, that will matter the most. Okay, so let's talk about the shapes of the different hearing aids. So number one, we have behind the ear hearing aid, we call it as BTE. BT stands for behind the ear. Now this hearing aid has different parts. What are different parts? Number one, we have a battery door. Inside you can place a battery. Nowadays we have some of these hearing aids which are even rechargeable hearing aids. So there is a rechargeable battery inside. You have to connect it to a charger, right? Then there is a on-off switch. N over here means switched on. O means switched off. So, okay, so remember O is for off. All right, then we also have a volume control. Now this volume control is generally seen in the basic BTE hearing aids. In the more advanced ones, there is no need of volume control, because when we have a Bluetooth, we also have a app. So there is a software app also, a Bluetooth app. You can connect it to a mobile phone, and with the help of mobile phone, you can adjust the volume and everything else. All right. Okay. And then what else do we have? We have a receiver. Now receiver is the most important part of the hearing aid. What is the function of this receiver? You see, this hearing aid, as I told you, it has a microphone. I have not shown the microphone over here, but it has a microphone. So there might be some hole, one or two holes, one microphone, two microphone. Unusually, we may also have three microphones. Okay, so there's a microphone, then there is an amplifier. So the microphone gives the sound to the amplifier amplifies the sound, then there is a receiver. So what is the function of this receiver? This receiver, it converts back this electrical signals which have been amplified by the amplifier, it converts them back into sound signal. Okay, so that is the receiver. Okay, receiver is not receiving the sound, receiver is converting the sounds which have been amplified. Okay, that's an electrical stimulus right now. So that electrical signal is converted back into the sound. So it gives it to a tube. So you see over here, there is a tube that is connected in a hook shape and is coming inside this plastic capping, and it reaches over here, and from there this ear plug is placed inside the EAC, and this hollow tube will bring the sound into the EAC, right? Okay, so that is our behind the ear hearing aid, BTE. Okay, so you will see that there is a hollow tube coming to the EAC, right? So you can see this is the how the BTE is applied. This is the hollow tube, and it comes and goes into the EAC, right? So this is the number one, the most basic one. Now it can have a lot of problems. All right, sometimes the sound which is reflected back by the tympanic membrane, that sound is also heard by this hearing aid, and there is a resonance. We call it as a feedback. Okay, this is known as feedback, right? Because this ear plug blocks the EAC, patient also has an occlusion effect, right? And that also creates a resonance of the sound, and patient is not comfortable. So if the patient is not comfortable with these problems, okay, so then we can go for another type of hearing aid which is known as receiver in canal. So now the receiver is placed inside the canal. All right, so you see over here, this part has the receiver also. So now there is no hollow tube. You see, there is no hollow tube over here. There is instead a wire. Right? Look at this hearing aid. So now you see that instead of the hollow tube, there is a wire which may be covered in a small silicone tube just to protect this wire. Right? And now it goes inside the EAC. And there the receiver is there, and that gives the sound. So it decreases the occlusion effect, it decreases the feedback, and gives a more natural sound. Right? So this receiver in canal hearing aids are used. Obviously, they are more costlier than the BT hearing aids, but the sound quality is better. Another effect of this is that they are little smaller than the BT. Okay, so cosmetically some patients, they like it. As you can see, they are less visible behind the pinna, right? Because they're smaller in size, right? Why? Because obviously we have removed the receiver from outside and we have put it inside the AAC. All right. Now, these are the hearing aids. Then we have hearing aids where cosmetic problems arise. Patients, they are very sensitive for cosmesis. They don't want the hearing aid to be visible. So, we have in the canal hearing aid. Now, in the canal hearing aid may have the same technology as the BT hearing aid, right? Only thing now is that now this hearing aid, all the machinery is placed in a small machine and you can put it in the canal. Okay, so when I say in the canal, you see some part is still visible outside. Although the hearing aid is gone in the canal, but it is generally in the cartilaginous EAC. Okay, some part is visible in the concha, right? Okay, now, so as to make this part disappear, to improve the cosmesis, now we have the CIC. CIC stands for completely in canal. Okay, so outside is not visible. As you can see, the outside is very less. So just because we are looking laterally, we are able to see this. Okay, and nowadays we have even more advancement than this, that is known as invisible in canal. So this goes almost near the bony EAC. So this is very, very small, you see. And if I put it inside, so this is still outside. When I put it inside in the EAC, you cannot see anything. All right. So it is very, very small. And all these hearing aids, the IIC, the invisible in canal, the CIC, that is completely in canal, as well as the ITC in the canal, all these three are custom made. Okay. So you have to take first a mold is used and you have to take the molding of the EAC. So take the size, the exact size, the exact shape of the EAC. The shape of every patient EAC differs. So we have to take an exact shape and size of the EAC with the help of a mold, and then according to that mold, these hearing aids, they are made by the company. Okay, so these are the different types of hearing aids. So this is based upon the shape. The technology, however, may remain same based upon what all features you have used. Okay, so all these different types of hearing aids can be made in the same technology. All right. Okay, so that was the hearing aids, the outer external worn hearing aids. Let us come to something more interesting, that is the middle ear implantable hearing aids. So there are people who don't want to apply the hearing aids. They don't want the hearing aid in the EAC. They don't want to apply them or remove them. They want the hearing aid inside. Okay, so they're the implantable, middle ear implantable hearing aids. So nowadays we have technology where we can implant the hearing aid inside the middle ear. We can directly, you can see over here, this hearing aid is directly giving the amplification to the stapes. So you can hang it on the stapes neck, right, and it will directly amplify the sound vibration to the stapes, which transfers it to the inner ear. Okay, so this hearing aid, you can see over here, it has a small microphone, amplifier and receiver outside. Okay, so that is the processor that will amplify the sound and it will give it inside. So that is the receiver. It receives these electrical signals, again modifies them into the sound, okay, and gives it, or into the vibration, the sound vibration, and these vibration then reach and they amplify the vibration of the stapes. Okay, so this is a middle ear implantable hearing aid. So as you can see over here, we have done a posterior tympanotomy. So remember, I have taught you posterior tympanotomy. Okay, you can see this is the posterior tympanotomy. In this posterior tympanotomy, you can see over here, this is the incus. All right, we can see over here that is the stapes, and on this implantable hearing aid is applied. Okay, so you can see it is attached to the incus, right? It is hanging just next to the stapes, and when it will vibrate, it will move the incus as well as the stapes assembly, and the sound will go into the inner ear, right? So depending upon the different types of hearing aids, you can attach them on the ossicles and they will vibrate the ossicle. But there is one problem. What is the problem? You see, there is still some part which is outside. Okay, you can put it on the skull above the pinna, but there is still some part, this is the rechargeable part, it is still outside. So some patients, they want complete cosmesis. They don't want any part to be visible outside, especially the actors, the actresses, they don't want. All right. So what you can do in these cases, you can apply a fully implantable hearing aid. Okay. Now this fully implantable hearing aid, it takes the vibration from the tympanic membrane. So you see, it takes the vibration, it is attached to the malleus. So malleus, it takes the vibration from the malleus. The vibration is given to this processor. The processor amplifies them. And then they are transferred back to the stapes, right? Okay, and the stapes vibration is amplified, and then those goes to the inner ear, right? These are fully implantable hearing aids. So we can use these fully implantable hearing aids also. But remember, whatever type of middle ear implantable hearing aids you are using, the prior condition is that the patient has to use the outer worn hearing aid for at least 6 months. Okay, and he should have a benefit with these hearing aids. So what you are doing is you are actually converting the external worn hearing aids to implantable hearing aids, right? But first, patient should have a benefit after using them for 6 months. If he's not having any benefit, there is no point in implanting the hearing aid. Okay, number one. And number two, patient should have a stable hearing loss. If his hearing loss is progressive, okay, then you cannot use these implantable hearing aids. Why? Because if the hearing loss changes after 1 year or 2 years, you cannot change the hearing aid. All right, so she should have a stable hearing aid, and he should have at least used the external body worn hearing aid for 6 months regularly, and he should have a gain with those hearing aids. Okay, so these are two prerequisites for using a implantable hearing aid. All right, now let's come to the next. We have the BAHA, bone anchored hearing aid. So remember the bone anchored hearing aid we discussed when we discussed the diseases of the external ear. Okay, so now this hearing aid is a special hearing aid. Why? Because it is attached to the bone. Now this hearing aid, as we know already, it has a titanium screw. Okay, this titanium screw is implanted in the skull bone. Titanium has a property. Which property? It has a property of bone integration. Okay, okay, you can also call it as osseointegration. So titanium metal, that's a property of the titanium metal. The titanium metal integrates with the bone. It becomes a part of the bone, right? So when the screw will vibrate, the whole bone will vibrate, right? That's the fundamental basis behind this type of hearing aid. So what is done in this? We have a processor, amplifier. Okay, so this takes the sound. It is the microphone, it takes the sound. Now it's a special type of hearing aid. It amplifies this sound and converts them into bone vibration. Okay, so you can see there is an abutment over here. This abutment, with the help of this abutment, we can attach this BAHA to the screw. So once the screw integrates with the bone, it takes around 2 to 3 months time after you implanted the screw. Okay, so after it is integrated with the bone, this abutment is applied and the hearing aid is applied on the abutment. So what happens over here? You see the hearing aid, this BAHA over here, it gives the sound, the bony vibration, and that vibrates the screw vibrates the bone, and through the bone conduction, the sound, it directly reaches into the cochlea. Okay, and the sound is given to the cochlea. So that means this BAHA, it bypasses your external ear and middle ear. I hope you are getting my point. It is bypassing both external ear and middle ear. The sound is directly going to the inner ear. That means if there is a problem in the external ear or in the middle ear, we can use this BAHA, bone anchored hearing aid. All right, so let's discuss. We have discussed one condition in the external ear disorders. So now we are going to discuss all the conditions where we can use this BAHA, right? So where all we can use this BAHA, the bone anchored hearing aid. All right, you see over in this diagram, this is applied over here in the skull. right? You can see the screw, and on this we will apply this Baha. Let's look in these few photographs. These questions are generally asked in the exam. Identify the hearing device. Okay, so this is a Baha over here. You can see that she's attached this to the device. Okay, so this is a wired Baha. You can attach it with the help of a wire to your iPod, to your cell phones. Nowadays we even have the Bluetooth Baha, so they have a Bluetooth feature, so you can directly connect even without a wire to the cell phone, to the television, and you can hear the different programs or different, you want to hear the music, you can hear the music also. Right, so let us discuss the indications of Baha. So what's the first indication that we have already discussed in the external ear diseases? The bilateral conductive hearing loss. So both the side there is conductive hearing loss, and which condition I am talking about? I am talking about bilateral EAC atresia, especially if there is anoxia also. So you cannot do any EAC atresia surgery before 5 to 6 years, 7 years, and you need something for hearing, okay, and that we can use in that case is Baha, because Baha gives sound directly to the inner ear. So you see the hearing results, they are best with Baha for bilateral EAC atresia, because when there is EAC atresia, there can be some problem in the tympanic membrane. Obviously there will be there if there is a bony atresia. Even with the cartilaginous atresia, there can be some problem in the middle ear ossicles also. So the best results of hearing are seen with Baha. So it's a very good device that can be used in bilateral EAC atresia. Then where else we can use? We can use it in case of chronic ear discharge, chronic otorrhea. So there is bilateral chronic otorrhea. Sometimes you have even done surgery to stop the ear discharge, but it has not stopped. The surgery has failed, right? And patient wants hearing. So you remember, if there is chronic ear discharge, you cannot put those conventional hearing aids which are worn in the EAC, because the discharge will destroy the hearing aid. Okay, it will block the hearing aid, so the patient will not be able to hear. If you are using a CIC or an IIC, they will be destroyed by the moisture. Okay, so even if you are using a BT hearing aid with a tube inside, an air tube in the EAC, the tube is blocked repeatedly because of discharge. So you cannot use conventional hearing aid in those cases, but you can use a Baha. Okay, where else can we use? We can use it in case of chronic otitis media or chronic otitis externa, because those conventional hearing aids, they become painful. So you can use a Baha. Okay, Baha is away from this ear, so the ear pain will not matter in Baha, right? Okay, number 4, if there is an uncontrollable feedback, the reflection of sound is too much, and that is when you have done a very big meatoplasty, because a lot of sound is going in. So after a meatoplasty or after a radical mastoidectomy, okay, so then we have uncontrollable feedback. In those cases also we prefer to use a Baha, right? Okay, then where else can we use Baha? We can also use Baha in a patient who's using a conventional bone conduction hearing aid, but he's not happy. Okay, he's not happy with this hearing aid or the sound of this hearing aid, so you can use Baha in those cases, because Baha gives a better sound, right? So conventional bone conduction hearing aid, patient who's not happy can also be taken up for Baha, right? Another indication, yes, there are some more indications. Patient has only hearing ear. Okay, so only hearing ear, it becomes a contraindication for surgery. Okay, it becomes a contraindication for surgery, such as otosclerosis, such as tympanosclerosis, okay, or such as canal atresia, because we believe if you touch this only hearing ear, there are chances that the patient may go into complete sensorineural hearing loss also. Okay, there is infection, you damage some part during surgery. So if there is only hearing ear, it becomes a contraindication for surgery, and then this patient can be taken up for Baha, because Baha, you are implanting the titanium screw away from the ear, on the skull bone. You're not touching the ear. All right, so in only hearing ear, we can use the Baha instead of doing a surgery. Then there is single-sided deafness. Okay, so patient has single side sensorineural hearing loss, right? Now, where can we use this hearing aid? Over here. Remember, there's only one side deafness, but this deafness, the bone conduction you see is less than 45 decibels, okay, and the SDS score is more than 60%. So you can amplify this with Baha, okay. So that means only one side deafness is there, and you want an hearing aid on this side. So instead of using the conventional hearing aid, some people they don't like the conventional hearing aid, you can use Baha also over here, right? Okay, so now we have discussed these indications of Baha. Now in all these indications I have talked about the problem which were there in the external ear. Okay, as you can see over here, conductive hearing loss, external ear or middle ear. Now we have also used in case of a conventional bone conduction hearing aid, that's number one, when the patient is not satisfied. Now can we use it in case of sensorineural hearing loss? Can we? Yes, we can use it. Where? In case of single-sided deafness. So what do I mean by single-sided deafness? I mean that let's say one side is completely deaf, no hearing at all, okay. Now patient is hearing only from this side, all right. So let's say the right side is completely deaf, the patient is hearing only from the left side. So what you can use in these scenarios, number one, cross hearing aid. So what is a cross hearing aid? Let's first understand what's a cross hearing aid. Cross hearing aid you apply on the right side. Now it will take the sound from the right side, okay, but we know so the right side is deaf, right side cannot hear. So now it will give the sound, so it will take the sound from this side and it will give the sound to the left ear, right? So what is the advantage of this? We're getting the sound of the right side also. So we have the sense of direction, which we called as the sound localization. So if we use a cross hearing aid, we can hear from the other side and we can have a sound localization. Now the same function can also be done with Baha. Okay, how? We put a Baha on this side. It takes the sound from this side, okay, and it amplifies it, it gives it to the bone. Remember, it gives the skull bone. Now from the skull bone, it is transferred to the other ear, to the other cochlea, okay, because the sound can be transferred across the skull bone to the other side also. So it is transferred to the other cochlea and patient is able to get the sound of this side also. So we can use Baha as a cross hearing aid also in case of single side deafness. Okay, that means single side dead ear, unilateral dead ear, we can use Baha. Okay, so single side deafness means unilateral dead ear, we can use Baha, right? But we need other functional cochlea. Just remember, we need other functional cochlea. If the other side cochlea is not functional, then we cannot use Baha because other side cochlea should be able to hear. Okay, that means that the better ear, out of the two, which is the better ear? The opposite ear. This better ear, the bone conduction loss on this ear should be less than 45 decibels. Okay, and the SDS score should be more than 60%, the speech discrimination score. Okay, the SDS, the speech discrimination score, it should be more than 60%. So in that case, we can use this Baha as a cross hearing aid also, right? So these are the indications of Baha. So are there some contraindications for Baha also? Yes, there are some contraindications. So what are the contraindications? Number one, as I just told you, if we are using it as a cross hearing aid and the opposite side, the bone conduction loss is more than 45 decibels or the SDS is less than 60%, then you cannot use this Baha. So that's the number one contraindication we just discussed as the last indication. Okay, number two, patient is emotionally stable, is not ready to apply this Baha, he snatches the Baha, has some psychiatric problem, okay, there is some developmental delay, he is not able to understand the sounds, right? Especially very common with EAC, atresia and anoxia. So there is one congenital anomaly, there can be other congenital anomalies, there can be milestone delays. So if there is a developmental delay, okay, so whatever sounds you are giving to the patient is not able to utilize those sounds, so there is no point in putting the Baha. All right, patient has a drug abuse. So again, this is a contraindication because this BAHA is an expensive device. So patient is liable to sell out this BAHA and use it for drugs. So drug abuse is also one of the contraindications. All right. And then age less than 5 years. So now out of all the contraindications, this is the most important contraindication, and let's study this contraindication. Why this is the most important contraindication? You see, for putting this BAHA, we need a bone thickness of 2.5 to 3 millimeter. Okay, now this bone thickness of 2.5 to 3 millimeter is achieved by the age of 5 years. Okay, so as per the US FDA, the BAHA can be implanted only 5 years or more than 5 years children. But suppose a patient has EAC atresia. Okay, a patient has bilateral EAC atresia. Okay, with bilateral anosia. No pinna, no EAC. Now this patient needs hearing. You cannot do a pinnaplasty till the age of 5 to 7 years because you need the rib cartilage, okay, the costal cartilage. They are developed by 4 to 5 years. So you have to wait at least 5 years, as I have taught you earlier. Okay, so now what will you do for this EAC atresia? So the US FDA guidelines are clear, that is more than equal to 5 years you can put the BAHA. Okay, but in case of UK has a NHS system, they have relaxed this criteria. Now what do they say? They say that between 3 to 5 years, you do a CT scan. Okay, you do a CT scan. If the CT scan shows that the bone thickness is somewhere near to 3 millimeters, then you can go ahead and do a BAHA. So between 3 to 5 years, they have given a small window where you can do a CT scan and check for the bone thickness. Now Indian government does not have a guideline. We usually follow the US FDA guidelines, but yes, in some cases you can do a CT scan and you can justify the implementation of this BAHA between the age of 3 to 5 years also. Right? So what do we do in a child who's less than 5 years or who has not achieved the bone thickness of 3 millimeter? What we do is we apply soft band hearing aid. So what is done in the soft band hearing aid? In this soft band hearing aid, the same hearing aid, okay, which we were using in the BAHA, the same hearing aid is attached to this soft band over here, and this child wears this hearing aid. Okay, the soft band keeps the hearing aid, this hearing aid which converts the sound into bone vibration. So the soft band keeps it near the skull bone, and now the hearing aid transfers the sound to the skull bone through the skin. Okay, so obviously the sound is not that good when you have a screw implanted inside the bone, but some vibrations, they go to the cochlea and patient is able to hear. Okay, so as we say, something is better than nothing. So obviously this hearing aid, you can use a little bit more amplification and you can give the bone vibration which reaches to the cochlea through the skin. Obviously after 5 years or after achieving the bone thickness of 3 millimeter, we can implant a titanium screw and we can take out this hearing aid and we can attach it on the screw with the help of the abutment in between, and the patient can keep on using the hearing aid. Okay, so the same hearing aid is converted back into a BAHA. Okay, BAHA is bone anchored when you have attached to the bone. But when you have not attached to the bone, but you are using it with the help of a soft band, so the same hearing aid is now known as soft band hearing aid. Right? Okay, so that was the BAHA. Now where we cannot use BAHA. So now I have shown you that the BAHA can be used in a lot of different situations, such as there are bilateral conductive hearing loss. It can also be used in replacement of a conventional hearing aid. It can also be used in case of a unilateral dead ear. Okay, so one side cochlea is completely dead, you can use it as a cross hearing aid, provided the other ear, the bone conduction is better than 45 decibels. It should not be, the hearing loss should not be more than 45 decibels and the SGS score should be more than 60%. Okay, so then we can use it as a cross hearing aid. All right, now where we cannot use this BAHA. Suppose patient has bilateral sensorineural hearing loss. Both sides are cochlear dead. We cannot use a Baha in that case. Okay, now we have to go for another type of hearing device that's known as cochlear implant. Okay, so we now go for cochlear implant. So cochlear implant, number one thing, this is not a hearing aid. This is not an amplifier. Hearing aid means you amplify the sound. Okay, the cochlear implant is not going to amplify the sound. This is the first thing you have to understand. This is a bionic sense device. Okay, it's a bionic sense device. So let's say both cochlea are dead, right? You are replacing the cochlea with a cochlear implant. So it is going to do the function of a cochlea. It's a bionic sense device. The cochlea, we have the sensory organ, the organ of Corti. Okay, so now instead of the organ of Corti, this implant is going to function. All right, so it is not an amplifier, it's a sense device. All right, now let's discuss the parts of the cochlear implant. So cochlear implant, the parts, components, number one is the external body worn component, the part that you wear outside on the body. Okay, and this has three important parts. Number one, we have the microphone that takes the sound. Number two, it has a speech processor. Now, what is the function of this speech processor? It takes the sound from the microphone. Obviously, there can be one microphone, there can be two microphones, just like in a hearing aid. But the important point over here is the speech processor. This speech processor takes the sound from the microphone and converts them into EM waves, electromagnetic waves. Okay, so now this is converting them into the EM waves. And then these EM waves are given to the transmitter. The transmitter transmits these EM waves, right? So now as you can see over here, this transmitter is attached to the skin of the skull. How it is attached? It is attached magnetically. Okay, there is no surgery. The surgical implant is inside. Let's look at the surgical implantable part, the second part of hearing aid. So we can see that this part, the surgically implanted part, has a receiver stimulator. Okay, so on this receiver stimulator, the transmitter is attached by a magnetic effect. Okay, so there's a magnet. So with the help of the magnet, this transmitter is attached to this receiver stimulator, which is surgically implanted below the skin, right? And the second part of the surgically implantable device is the electrode array. So this electrode array goes inside the cochlea. Okay, which part of cochlea? The scala tympani. So the receiver stimulator, it receives the EM waves. So remember, the transmitter over here, this transmitter was sending the electromagnetic waves, the EM waves. They cross the skin and then they are received by the receiver. So it's not just a receiver, it's a receiver and stimulator. So it receives the EM waves and it converts them back into electrical signal and it stimulates this electrode array. Okay, so when it stimulates the electrode array, now the electrode array goes inside the cochlea. So it is implanted in the scala tympani. Why we implant in the scala tympani? Because in scala tympani, it is nearest to the 8th nerve, the cochlear nerve. So it stimulates the cochlear nerve, right? The electrode array, it stimulates the cochlear nerve, right? So this is how the cochlear implant works. All right, now let's look at the indications of cochlear implant. So what are the indications? Indications, whom to implant. So patient has to have bilateral severe to profound sensory neural hearing loss. Remember, if there's a unilateral sensory neural hearing loss, we don't need a cochlear implant. We can even do a Baha. So why to go for cochlear implant? So in case of unilateral sensory hearing loss, we don't need to do a cochlear implant. Why to do a cochlear implant? We can even do a Baha, or we can put a cross hearing aid. So this has to be done only when there is bilateral severe to profound sensory neural hearing loss. So what do we mean by severe and profound? We have already studied. Severe means more than 70 decibels. So in adults, more than 70 decibels, and in children, more than 90 decibels. So that's profound. Okay, so remember, profound and severe definition. So these are as per the Clark definition of hearing loss. So adults more than 70 decibels and children more than 90 decibels. Okay, that's the first indication. Anything else? The patient should have a poor speech perception. So poor speech perception means the SDS score, the speech discrimination score, should be less than 20 to 30%. Right? Okay, and number 3, very important. Okay, so all these have to be there. Not just one, all these 3 have to be there. There is no improvement with hearing aids. So again, patient should apply the hearing aid for 6 months at least. Okay, and even after applying for 6 months, there is no improvement with hearing aids, then we will go for the cochlear implant, right? So there are the 3 indications. And number 4, we don't implant in less than 1 year. So the age, let's say limit, we don't implant in less than 1 year. Why? Because it is not US FDA approved. Yes, a few studies have been done where the patient has been implanted hearing aid at the age of 9 months or so, but we don't implant usually. That is only for research purposes. Okay, so the US FDA approval is more than 1 year. The study for 9 months is for research. We want to research also. So sometimes we take the clearance, but the allowed limit is 1 year and above. Why? I will tell you. Okay, now priority. So what do I mean by priority? Suppose you have one hearing aid. Suppose in a country like ours, India, developing country, we don't have cochlear implant for everyone and anyone. Okay, there's a government funded scheme where you are giving cochlear implant free to a patient. So whom will you prefer? Okay, whether you will prefer a child or you will prefer an adult. All right, obviously you will say we'll prefer a child. Why should we prefer a child? Because if you implant in a child, the cochlear implant is going to stay for a longer time. The child has supposedly many more years, 30 years, 40 years, 60 years, 70 years to live. So a child will be more productive. All right. So obviously if you have limited resources, you will give to a person who can use it for a longer time, who will benefit himself and the society more. So a child is given more priority as compared to an adult. Okay. Then we can also have prelingual deafness and postlingual deafness. So what do we mean by prelingual deafness? Prelingual deafness means before development of language, before development of speech. Okay, so prelingual deafness means before development of speech or language. Postlingual deafness means after development of speech or language. So now out of these, what will you prefer? You see, now there are 4 criteria, 4 categories. We have prelingual child, postlingual deaf child, we have prelingual deaf adult and postlingual deaf adult. So out of these 4, which one you will give the maximum priority? Okay, there are 4 categories now. So obviously we have seen that from the child or adult, you will give more priority to child. Now, whether you will give more priority to a prelingual deaf child or a postlingual deaf child. Now you see, many students answer to me over here that we'll give more importance to prelingual deaf child. No, we'll give more importance to a postlingual deaf child. Why? A postlingual deaf child means this child developed speech. Okay, the child developed speech. Then because of some reason, he lost hearing. Okay, so that means when the child was born, the child had hearing. Because of the hearing, he developed speech. So he developed speech means he developed language also. Okay, he developed an understanding of the language. And then because of some reason, some disease, he lost the hearing. Okay, so number 1 thing, this child is less likely to have any congenital anomaly in the ear. Number 2, very important point. If you implant a cochlear implant in this postlingual deaf child, he will immediately catch the sound. He has an understanding of that sound. He knows if you say ah, it means ah. If you say e, it means e. He can recognize those different sounds, those different vowels, those different consonants. He knows those words. So you don't have to teach him those words. You implant, he has the speech, he starts understanding the speech, okay, and he's able to function immediately. Whereas a prelingual deaf child, okay, now this child has not developed any speech. So that means he lost hearing either congenitally, he didn't have a hearing, or he lost hearing before he developed speech. So prelingual deaf child. So number one, there are chances of congenital anomalies in the ear of the patient. Number two, this prelingual deaf child does not have an understanding of the language. So even after cochlear implantation, you have to teach this child the language. So there is always a question mark. He may not understand the language. He may take a lot of time to understand the language. Okay, so this patient's, the understanding of the language will take some years, some months, sometimes years. So therefore, the maximum priority is always given to a postlingual deaf child. Okay, remember this thing, postlingual deaf child, this is given the maximum priority. Okay, and therefore, by this criteria, we also come that suppose there is a prelingual deaf adult. If there is a prelingual deaf adult, so that means the patient is adult over here, I mean more than 7 years. Okay, not 12 years, not 18 years, I'm saying more than 7 years. So prelingual, that means he did not develop any speech, and now is a prelingual deaf adult. So now adult, even I'm saying even if it's a child more than 7 years, now we don't implant this patient. Okay, we don't implant because these patients, they do not benefit at all with cochlear implant. Okay, so prelingual deaf adult, we don't implant. All right, so we'll go to that in the contraindications of the cochlear implant, but this was the priority. The maximum priority is given to the postlingual deaf child, and this is an MCQ that you should know. All right, now let's come over here to the process of cochlear implantation. So we know for cochlear implantation, we first do a cortical mastoidectomy. So this we have already studied. We have studied the different walls of the mastoid. We know this is the common wall, the interior wall of mastoid, the posterior wall of middle ear. We have the facial nerve over here. This is the chorda tympani, and in between them, this area that I am now shading, this is your facial recess. And what do we do in this facial recess? Okay, in this facial recess, we do over here, we do a posterior tympanotomy. So we have discussed all this in the anatomy of the middle ear and mastoid topic. So we do a posterior tympanotomy over here. Through this, we enter into the middle ear. Right, let's look at a photograph of the posterior tympanotomy. So this is the photograph of posterior tympanotomy. Again, we have discussed this earlier. We can see the facial nerve, we can see the chorda tympani, we can see the lateral semicircular canal, the bulge, the incus. So that is the place where we have the fossa incudis, right? So that is the place for fossa incudis, the upper boundary of the posterior tympanotomy, and in between them you make an opening, you enter into the middle ear. Now what we can see over here, we can see over here that this is the round window. Okay, so that's the round window. Anterior to the round window you can see the bulge. So that bulge means it is the promontory. So now how do we enter into the cochlea? We have to go into scala tympani. Remember, we have to go into scala tympani. So we can enter into scala tympani through this round window. So number one, we can go through round window, but round window, sometimes the position is little bit oblique. So you are not able to go through round window. Surgically it is difficult. Then you make a hole near round window. Okay, so you make a hole near round window in the cochlea. So if you make a hole, that is known as cochleostomy. All right, so remember, you go through round window or you make a hole near round window. Okay, you make a hole anterior inferior to round window. Okay, this hole is known as cochleostomy. So this is again a photograph of the posterior tympanotomy, right? You can clearly see over here the facial nerve, you can see the chorda tympani. Okay, and you can see that is the incus. This is the lateral semicircular canal, and you can see in between the posterior tympanotomy has been done, right? And then you make a cochleostomy, so you can see the round window over here. So you make a hole, or you can directly go through round window, and you can see in this implant, this cochlear implant has been implanted through the round window into the cochlea, scala, tympani. There it goes, and it stimulates the eighth nerve, right? Okay, so now let us come to the important topic, the contraindications of cochlear implant. So what are the contraindications? It's an important topic. A lot of questions are asked from this in the exam. So what are the contraindications? We are going to discuss the absolute contraindications for cochlear implant. Okay, so what are the absolute contraindications? Number one, I have already discussed with you, a prelingual deaf patient. That is, when I say prelingual deaf patient, more than equal to 7 years. I told you prelingual deaf adult, it's an absolute contraindication. So when I say adult, even more than 7 years, we don't implant. Now, why don't we implant? We don't implant because of a phenomena that is known as neural plasticity. Okay, what is neural plasticity? We know we have the auditory cortex over here, then there is a Wernicke's area that understands the speech, then we have a motor speech area. Now what happens? The patient is not hearing. Patient is not hearing. So what happens? The neurons in this place, they will start working for something else. Okay, so instead of the hearing, they will take up some other function because there is no hearing stimulus. So our brain is a very, very easily modifiable organ. Okay, it's like plastic. You can easily modify a plastic. So similarly, the brain, the neurons of the brain, they don't sit idle. You don't give a stimulus them, they will start doing something else. So in these patients, because there is no stimulus, okay, till 7 years of age. Now in 7 years of age, the neural plasticity is complete. So that means all the neurons in the auditory cortex, they have taken some other function. So now after 7 years, even if you put a cochlear implant, it stimulates the eighth nerve. The eighth nerve takes the electrical signal to the brain. The auditory cortex is no more there. This cortex has converted into something else. So it cannot recognize the sound stimulus. So because it cannot recognize or understand the sound stimulus, the patient will not perceive these sounds or will perceive them only as a noise. Right? So we don't implant in patients more than 7 years of age, especially the prelingual deaf children. Right? Then what are you stimulating? You're stimulating the eighth nerve. There is no eighth nerve. Let's look in this. This is a normal CT scan in which we can see the eighth nerve. You can see it is entering to the cochlea. Right? Look in this photograph. You can see in this CT scan over here, this is the cochlea and there is bone over here. You see, that means the nerve is not entering, the eighth nerve is not entering to the cochlea. Okay, there is eighth nerve aplasia. The eighth nerve is not completely developed. Right? Okay, so we have a eighth nerve aplasia. You cannot stimulate something that is not there. Right? So eighth nerve aplasia, again, an absolute contraindication. Then you have a eighth nerve tumor. We discussed about neurofibromatosis type 2 with bilateral vestibular schwannoma. So as you can see over here, patient has bilateral vestibular schwannomas. So you are going to do the surgery. In these patients, these tumors are more aggressively growing. By the time they are discovered, they are generally large, as you can see over here. So you have to do surgery on both the sides. So when you do surgery, you are going to cut the eighth nerve. All right. So you cannot put a cochlear implant. Right? Where else you cannot do? You cannot do in Michel's aplasia. What is Michel's aplasia? No cochlea. So if there is no cochlea, obviously you cannot implant a cochlear implant. Where will you implant? Right? Look in the first photograph. You see over here, there is no cochlea. Look on this side, we can see the cochlea. So that's the cochlea. Okay, but on this side there is no cochlea, there is absent cochlea. We just see the vestibular part. Look in the second photograph. So when we look in the second photograph, you can see that there is almost no inner ear. Okay, there is no inner ear at all. Right, so we have a Michel's aplasia, no cochlea. All right, then we have a Sheath's dysplasia. Now, Sheath's dysplasia, you can also call it as cochleosaccular dysplasia. Now, remember cochlea and saccule, both of them develop from pars inferior. So, it is also known as pars inferior dysplasia. That means during development, they have not separated. So, they are only one. We have a big cavity, cochleosaccular dysplasia. Now, remember, this is the most common congenital anomaly of inner ear. Okay, and it is an absolute contraindication because cochlea is not developed. All right, in these cases, the cochlea may not be there, or the basilar membrane is not there, and the cochlea, only the some part of rhizomous membrane is there. So we cannot implant in these cases. Okay, it's absolute contraindication, Sheath dysplasia for a cochlear implant. Now next we have Monni's dysplasia. Now first thing about Monni's dysplasia, this is the most common congenital anomaly of cochlea. So remember, when I said Sheath's dysplasia is the most common congenital anomaly of inner ear. Inner ear means both the auditory inner ear, the auditory labyrinth, as well as the vestibular labyrinth. Right? Now, over here, talking about Monni's dysplasia, this is the most common congenital anomaly of cochlea, only the auditory labyrinth. Right? So remember, don't confuse in the exam, two different anomalies. All right. Now, what happens in Monni's dysplasia? We have already discussed in the inner ear disorders. There is only 1.5 turns of cochlea. Okay, only 1.5 turns of cochlea. The second and the third turn, they are fused together. So we have only 1.5 turns. Right? Okay. Now, so we have only half the cochlea, you can say. Roughly nearly half the cochlea that we have. So that means the sensory epithelium in the eighth nerve will only be half. Right? So if you stimulate the eighth nerve over here, only half of the eighth nerve will be stimulated because the cochlea only developed only half. All right. Therefore, we don't prefer to do a cochlear implant in Monni's dysplasia because you are putting an implant but you're getting only half the result, half the response. Okay, so Monni's dysplasia is a contraindication, but listen to me carefully. It is a contraindication, agreed, but let's look in this patient. In this patient had bilateral Monni's dysplasia. Okay, this patient had bilateral Monni's dysplasia. So now what will you do? You see, if you implant in Monni's dysplasia, as I said, a glass can be half empty or it can be half full. Right? It can be half empty or it can be half full. So first we said it's a contraindication because we are getting only half the response. But if let's say there is one side cochlea is a complete cochlea, other side is a Monni's dysplasia. So what will you do? You will implant on the side there is a complete cochlea. Okay, but let's say there is bilateral Monni's dysplasia. Like in this situation, patient has bilateral Monni's dysplasia. Now what will you do? Now you don't have an option. Okay, you have to implant in one of the cochleas. At least you will get 50% response. Right? Okay, so Monni's dysplasia is not a absolute contraindication. It is a relative contraindication for cochlear implant. Okay, this is what I wanted to highlight for you. This question has been asked in the exam. Which of the following is not a absolute contraindication? So remember, Monni's dysplasia is a relative contraindication. Remaining all that I told you before this were absolute contraindications. But Monni's dysplasia, you don't prefer to do a cochlear implant, but if bilateral Monni's dysplasia is there, or let's say one side there is no cochlea, other side there is only Monni's. So in those scenarios, you will implant in the Monni's dysplasia. Right? Okay. Now, these were the indications, the contraindications, how we implant the cochlear implant. Now, patient has absolute contraindication for cochlear implant. You cannot implant a cochlear implant. What will you do? Patient wants hearing. Let's say patient has bilateral vestibular schwannoma. Okay, we have done surgery, you have removed the bilateral vestibular schwannoma, but patient wants hearing. So what will you do in this scenario? In this scenario, you can go for auditory brainstem implant, ABI. So ABI, now remember the E. coli. First we stimulated the eighth nerve with the help of cochlear implant. We are not able to do that. Now we can go to the cochlear nucleus. Okay, so auditory brainstem implant, it stimulates the cochlear nucleus. Where is the cochlear nucleus? Cochlear nucleus is in the brainstem. Okay, where in the brainstem? It is in the fourth ventricle. Okay, where in the fourth ventricle? It is in the lateral recess. So you see, you got all the answers. So the ABI, the auditory brainstem implant, is implanted in the lateral recess of the fourth ventricle, that is the brainstem, and there it stimulates the cochlear nucleus. Remember, cochlear nucleus, I have told you, is also known as spiral ganglion. So okay, so it stimulates the spiral ganglion, and there you hear. Now, this ABI is similar to a cochlear implant. The structure, the external component, the internal component, they are all same to a cochlear implant. Only difference over here is the electrode array. Okay, remember, in case of a cochlear implant, the electrode array goes inside the cochlea. So it is a tubular. Okay, and the arrays are arranged one by one. Now, over here, this electrode array goes inside the brainstem on the cochlear nucleus. So it is like a brush, right? So the electrode array shape has changed. Also, the more you go near to the brain, the more complex a device you need, right? And therefore cost will be more. And the more you go near to the brain, the poor the response will become. So a cochlear implant is much better than auditory brainstem implant for hearing results, because you will need, as you go near to the brain, you will need a much more complicated device. Okay, sometimes the device has to be so much complicated that the technology is no more advanced till that level. Okay, so therefore a cochlear implant will give a sound which is better than ABI. A Baha gives sound which is better than cochlear implant. Okay, so I hope you are getting my point. The simpler the device that you can get, the more, the better the sound will be, right? So yes, we use cochlear implant when we cannot use Baha. We use ABI when we cannot use cochlear implant. All right. So what are the indications of ABI? The indications of ABI are the absolute contraindications of cochlear implant. Simple, easy to understand. So whatever absolute contraindications of cochlear implant we just studied are the indications for ABI, such as we have eighth nerve aplasia on both the sides, bilateral. Okay, we have cochlear aplasia, there is no cochlea, Michel's aplasia on both the sides, bilateral. We have bilateral vestibular schwannomas, so we'll do a ABI, right? So in these scenarios, we will do a ABI. All right, so before we end the topic, let's discuss the question: site for implanting an electrode in auditory brainstem implant. So this is a NEET January 2018 question. Answer we know now is the recess of the fourth ventricle. Okay, now how do we go inside the fourth ventricle? Okay, another question that can be asked: how do we go inside the fourth ventricle? So remember, from the fourth ventricle comes out the CSF. Okay, the CSF comes out into the subarachnoid space. Okay, and how does it comes out? It comes out through the foramen of Luschka and Magente. Okay, so it comes out of the foramen of Luschka and Magente, and we use this foramen of Luschka to enter into the fourth ventricle, and there we implant the auditory brainstem implant, the ABI. So sometimes this question can also be asked: how do you enter into the fourth ventricle for putting the ABI? Your answer is through the foramen of Luschka. Right? So this was all about the hearing devices, starting from the outside to the inside till the level of the brainstem. We can stimulate this neural pathway of sound, and we can give the hearing rehabilitation to a deaf patient. Thank you. you.